This is Scott Becker with the Becker's Healthcare Podcast. I'm thrilled today to be joined by Dr. Rob Karpinos. Dr. Karpinos is both the chairman of anesthesia at St. Barnabas Hospital. He's also the assistant vice president and director of perioperative services and medical anesthesia. Today we're going to talk to Dr. Karpinos about a really critical subject, and that's the opioid epidemic and narcotic avoidance, and how to continue to improve upon narcotic avoidance to help reduce the impact of the opioid epidemic. Today's podcast is brought to you by Somnia Anesthesia, a leader in hospital-based and ambulatory-based anesthesia. Dr. Karpinos, can you take a moment to introduce yourself, and then we'll talk about a number of issues relating to how to treat pain without narcotics, what's happening, the state of the art, and a lot more. Dr. Karpinos?
Thank you, Scott. It's a pleasure to be here, and I very much appreciate the introduction. As you mentioned, I am the chairman of anesthesia here at St. Barnabas Hospital in the Bronx, as well as the medical director and AVP of perioperative services. A passion of ours here at St. Barnabas to reduce the use of unnecessary opioids, work that we're quite proud of, and we'd love to share it with you.
Thank you so much. And talk for a moment, Dr. Karpinos, how has pain management evolved in recent years? What are some of the trends, and what are you watching?
So, pain, Scott, is really a very complex set of medical conditions, from symptomatology to the diagnosis, which can often be quite elusive. And unfortunately, we as physicians don't get very, very much training and background in pain management as part of a standard medical curriculum in the United States. So what began really back in the early 90s was a recognition by the pain societies, the American Pain Society, that pain was sometimes undertreated and overlooked. And they felt as if pain should be considered like a vital sign, prominent on the patient's chart. They felt that the interventions needed to be mapped and followed, and that we needed to report successes and failures the same way we would management of any other vital sign. And it's this initiative that was spirited in good hopes of better outcomes that kind of went astray. The initiative was first picked up by the Veterans Administration and made a national objective in the late 90s. And then later by the Joint Commission and the Robert Wood Foundation and the University of Wisconsin all came together and created what were called pain standards. These pain standards in the early 2000s were pushed out by the Joint Commission as standards. And unfortunately, this is where things kind of went awry. Once these things become standards, they get equated to quality of care and ultimately payment patterns. So now you have physicians with maybe not universally the best background in pain management being charged by standard to ensure that patients are pain-free. What ends up happening is the pharmaceuticals recognize an opportunity and send in their detail reps to provide the physicians with background information and some guidance. So it's a multifactorial problem that we faced. We as physicians, without a great background in many, many cases, and the pharmaceuticals coming to provide us creates somewhat of a conflict. To provide us with that education creates somewhat of a conflict. Nonetheless, that's what we faced. And unfortunately, some people may have been a little more direct and clear and honest, while others maybe not. Now, there was, if we go back to the early 90s, a belief and a kind of hope that using narcotics to treat pain would not create addictions if it was being used in severe pain conditions. Unfortunately, that's just not so. And many of the references to the lack of addiction and addictive potential of narcotics came from a very frequently cited reputable journal. Unfortunately, it wasn't a full-length article and there was no science behind it. It was really an opinion and a letter to the editor. And it's that type of mis or disinformation that really led us astray. So what we end up with is an overuse, an excessive use of narcotics that really are dangerous and do have addictive potential, and really haven't been shown to be, absolutely effective in all chronic pain conditions. Also, we then run into an instance where we develop an appreciation for this, and we're starting to see, as early as the late 90s and early 2000s, this epidemic of narcotic overdose. Now, if we go back and look quickly at the heroin epidemic in the United States in the 70s, that accounted for about 2 deaths per 100,000 populace. In the 80s, we had a cocaine epidemic, accounted for maybe 3 to 4 deaths per 100,000. The current narcotic crisis that we're looking at accounts for over 20 deaths per 100,000. Just to give you some staggering statistics, from 1999, there's approximately 850,000 opioid-related deaths, highest rate ever of 93,000 in 2020. This is almost a 30%, 29.4% increase from 1999, where we had been averaging about 70,000 mortalities per year. So really just a devastating problem. And the AMA has even recognized and published that the opioid crisis has gotten worse as we come out of the COVID crisis.
So, Dr. Karpinos?
Yeah.
Let me. I know that the stats are overwhelming. Like literally went from about 65,000 or so, 60,000 deaths to 93,000 last year. People thought the opioid epidemic was moving in the right direction, and now over the last couple of years, it's moving back in the wrong direction. There are some new standards, some new ideas, new thoughts. What should listeners know about the Joint Commission's new emphasis on narcotics avoidance? Then we'll ask you about how can health systems and providers create pain management programs that limit narcotic exposure but do help patients manage their pain. Talk to us first about the Joint Commission's new emphasis on narcotic avoidance.
Well, I think the Joint Commission, while they never said to use narcotics to treat pain, they do recognize their role in this by creating these standards. And what they've done now is to try to negotiate, if you will, a better solution, which would be to avoid the narcotics in the therapy of pain. So what they've released, I believe it was back in 2019, was guidance that suggests that, there should be in each hospital a recognized group of people, a pain management committee or narcotics stewardship committee, if you will, that oversees the use of narcotics and ensures appropriate education, appropriate alternatives, alternative modalities to narcotics, and that this committee and group should be really multidisciplinary, as pain is a multidisciplinary problem. So I think the Joint Commission is, on the right track, trying to help us in the medical community to get ourselves out of this conundrum that we've created. And you're absolutely right. The statistics have shown an improvement. One of the big problems that we faced was, especially in acute pain, is the linear relationship between duration of narcotic therapy and the risk of addiction and continued use. And in 2012, we peaked with about 81 scripts per 100 persons. 2020, we're down to 43 scripts per 100 persons. So that's going in the right direction. What we need to add, and what the Joint Commission has assisted us in adding, is the other 2 parts of the equation, or 3 parts of the equation, which include treatment for those who are already addicted and struggling, as well as methods and routes for return of unused narcotics, because the illicit and the extra doses that are available that become illicit use heavily contribute to the problem. In addition to prescribing alternative methods. So you have, and treatment for acute overdose.
Help me for that again real quickly, because what you said was astounding to me. The number of prescriptions written with narcotics is down tremendously over the last, let's say, 5 years.
Yes.
Yet we've got deaths peaking back up, significant 30% increase. And so less of it's you would think that at one point a lot of this was blamed on multiple factors, but part of it was based on the medical community, part of it was based on the distribution network, just a crazy amount of narcotics distributed.
Yep.
But some of that has tracked down now, but yet we're still seeing, and last year was an abominable year for people's mental health,
yes,
given the pandemic and everything else. But talk again, because providers are already doing, it seems like, a much better job of reducing the amount of narcotic exposure from the stats you suggest. What else can providers do to reduce narcotic exposure?
Well, really, we need to reduce it even further. And again, recognize that linear relationship between duration of therapy and a second prescription almost doubles the rate of prolonged use. The prescription rates are down to 43 per 100 persons. That's one prescription for every other person out there. And in some counties, they're still quite high, with one per person or even more than that. So I think we're doing a great job. We need to do a better job at limiting those post-operative and long-term prescriptions. And many states have legislated this.
Right.
The
so
problem
when you say, but let me just make sure that the audience has the stats right, because what happens is we see all these stats all over the place, and when you say 43 out of 100, that's not 43 out of 100,000. That's not 43 out of 10,000. That's literally 1 out of every 2. And then your point is those are still way out of whack in some places where it's 1 to 1, close to 100 per 100. And then also the duration that somebody stays on opioids, narcotics, is a big indicator. I mean, you see this, anybody has a knee replacement. I see my mother-in-law get a knee replacement. You could almost see where this could happen. She stays on a little bit longer. She's more likely to be addicted. I mean, you see this very upfront and personal for all of us. But to talk about some of those things that could help reduce it further. This
is absolutely true, and you're right on target. When patients have painful postoperative syndromes, the states have legislated that we shouldn't be prescribing more than 7 days worth of therapy because that's what's considered reasonable. We have to start building in the alternatives right from the start. And we can't just depend on the narcotics for the post-op duration, or we're going to continue to see second prescriptions and continued addictions. It's really essential that we include prehabilitation, operative narcotic avoidance where it's able to be done. And for example, in orthopedic surgery, there's a huge shift to regional anesthetics rather than general anesthetics, and using a traditional narcotic-based anesthetic plan. And then in the post-op phase, to really limit the use of narcotics and seek alternative therapies. In addition, the big problem that you've identified is despite the decreased number of prescriptions, there's leftover pills which are used illicitly or incidentally. And then there's a transition from people who have low or moderate level addictions after short-term exposure to seeking narcotics illegally. And again, this is where we, the medical community, need to understand that we do contribute to this. It's very easy to look at narcotic mortalities and see the rise in heroin use and illegal fentanyl use, and to say, well, I didn't write the prescription for fentanyl. But these are where people are going to treat their own addiction, to satisfy, not treat, but to satisfy their addiction, is to the illegal avenues when they run out of and can't get more prescriptions for what they're seeking. So again, take it back. Really, the root of this sits in change management. It sits in recognizing the urgency, creating strong coalitions and strong education in order to change the way we treat pain in the hospital, and then on the post-op phase, and then for chronic pain. We need to partner with the patient so they understand that we cannot continue to prescribe long-term narcotics, and that there are alternatives out there that can be good at treating pain, good at satisfying the need for analgesia, and not as nearly as addictive.
Thank you. Talk about some of the benefits of these kinds of pain management programs where they become far less reliant upon narcotic exposure or really trying to limit narcotic exposure. Talk about some of the benefits of this.
Well, so we here at our institution recognize some of the work done at the University of Michigan that reported a 6% continued use rate in narcotic-naive patients that have never had narcotic use after a single exposure in the perioperative arena. So we took that kind of information and we started as an institution-wide project to decrease our narcotic use, and we were very successful and decreased our institutional use by about 30%. But then in the anesthesia environment, we recognized that there was room for further improvement, and we employed what we called substitution therapy. Now, again, we allowed and encouraged our clinicians to use clinical judgment, and where there was a need for narcotic, we still use it when it's appropriate. We just pushed it to the second or third line therapy. And what we did was employ alternatives. So, there are some patients that are perfectly able to accept non-steroidal analgesics. There are some that we can use other agents at very low dose, which may be less addictive. And there are some that are, simply haven't been shown to be addictive at all in place of the narcotic-based therapy. And what we do here is, by moving the narcotic to the third or fourth line therapy and treating the pain early and treating it ahead of time and treating it well, we decrease the ongoing need. We decrease the amount of drug that's available in the community and maybe improperly returned. We've also implemented programs to allow easy return without stigma of excess narcotics. And then we really have to, in these programs, have to address patients that have underlying addictions and conditions that make them more susceptible to addiction as part of this multifactorial, multidisciplinary approach to pain management. And in doing so, the community sees less, there's less illegal drug seeking, and everybody really becomes healthier.
But your point on it's fascinating how much of the narcotic use is not prescribed by a doctor for that patient, but is leftover pills that end up getting used by somebody in the household, a neighbor, a friend. How much of there's a transfer of this kind of stuff around, isn't there?
There absolutely is. In fact, up to 75% of people who are addicted and use heroin will report that their first exposure to narcotic was either a prescription or, more commonly, through a friend, left over in the house, and just used illicitly.
Thank you. And take a moment, Dr. Karpinos. I mean, it's such a fascinating discussion. I mean, it's so interesting because until this past year, we all sort of thought this was going in the right direction. And then I am always amazed at how much narcotics are around. As you see family members have surgery and so on and so on, there's just so much around still. Yeah. But we thought it was really going in the right direction. And then during COVID, these numbers skyrocketed back up in terms of deaths from opioids and so forth. What else is there that is important to mention that maybe we didn't cover yet, that you could mention that we haven't covered or talked about yet?
Well, I mean, I think that, again, it goes back to the underlying education in pain and painful disorders, as well as behavioral medicine. And there's just, again, COVID is one of these aberrations in history that we'll look back on and see in the future that things were just incredibly difficult to manage. You're asking people to isolate for prolonged periods of time. These have all kinds of impacts on mental health. The rate of alcohol sales skyrocketed during COVID. It's really no surprise or stretch of the imagination that people who were unable to see their physician, unable to get alternative therapies, unable to get in and be seen, would resort to any method they could, whether it be psychological, emotional, behavioral, or true pain disorders, to find comfort. Really just an incredibly difficult period of time for everybody.
It sure is. And let's hope. I know we're seeing surges again in Europe. Let's hope that we're sort of that enough vaccines, enough everything will lead us sort of out of the struggle here over time so we can all get back to more normal living, which hopefully will reduce, at least it'll have some impact on behavioral health and addiction community and so forth.
Absolutely.
Dr. Karpinos, I want to thank you for joining us today on the Becker's Healthcare Podcast. Just a pleasure to visit with you. Such a huge issue with still a huge increase in deaths, even though we're reducing the number of prescriptions written with narcotics for pain management. So such a pressing and such a critical issue. I want to give a special thanks to Somnia Anesthesia. Somnia Anesthesia is the sponsor of today's podcast, and we just love a sponsored podcast where it's truly just information and nobody's selling anything. Again, Somnia Anesthesia, magnificent hospital-based and ambulatory-based anesthesia firm, staffing firm, and leadership firm practice. Thank you so much for joining us today. Thank you to our audience. Thank you.